First side effect to think about is what? Hypertension as an antihypertensive drug. And the other thing will be what? Bradycardia, exactly. طيب لأن لو صار في عندك hypertension وbradycardia then في global بالنسبة للheart function. Okay, rest in the heart. What will your body feel like? Exactly. Something that you will feel all the time is fatigue, exhaustion. You don't have enough energy or power due to that depression of the heart function. Another thing, when you decrease the blood flow to the brain, if that happens, something that might happen also is insomnia. So patients might come to you after starting the beta blockers complaining of insomnia, being unable to sleep for long periods of time. And another thing that you have to take care of, particularly when you prescribe beta blockers for young people, and as we said, actually it's the first line in young people. What organ depends, or what function of an organ depends particularly on good blood flow? See? Something more important for people. The genitals, exactly. So something that's commonly encountered in practice is that young people come to you complaining of sexual dysfunction, erectile dysfunction, after using the beta blockers for at least during the first few months. So one way around that is what? And I have told you several times, when you know a common side effect, a problem that might bother your patient, always try to communicate well with your patient at the first time. Okay? So if you introduce that to your patient at the beginning, he will be aware of that. Okay? Instead of being so scared and afraid all of a sudden of losing that function. And it's his choice at the end of the day. So sexual dysfunction is very important to be communicated with your patient. The last type of the adrenergic blockers we talked about yesterday were the central sympathetic agents, which means what? Drugs that will go into the central sympathetic centers within the brain to inhibit them. Now, have you ever heard of the alpha-2 receptors? What's their function? Exactly. So it's the negative regulation of the sympathetic system. So it inhibits the sympathetic flow. So what should I do pharmacologically if I want to block the adrenergic function? Exactly. So what we use here is an alpha-2 agonist. It's a sympathetic, but we are using an agonist. Now once that agonist works, that will lead to inhibition of the global sympathetic activity. Now that's good. Why? Because we will be targeting the whole cardiovascular system. So we will inhibit both the cardiac stimulation and the vasoconstrictive power of the alpha-1 signal. Okay? And that will lead to comprehensive reduction of blood pressure. Now, the drug that is most commonly known in that group is clonidine. Okay? Again, this is an alpha-2 agonist, so it's a centrally acting sympathetic agent. Now, should you prefer to use this class of drugs? If no, why? If yes, why? مين يعني بحب إنه to use this drug as a first line? أنت إيش بدك يعني يكون first line ولا last resort؟ ليه؟ Okay. Nice. Okay. So your colleague thinks that this should be the last resort because I'm going to inhibit the whole sympathetic flow. Okay? The effect will not be particular to the cardiovascular system. It will be everywhere. But if I want to talk about the cardiovascular, what's the problem of inhibiting the whole sympathetic function? Something we discussed yesterday. Yes, please. That's not the most important thing. على شرط. Okay, but no, that's not the biggest problem. Yeah, as we said, it's mainly controlled by alcohol. Okay, now, yes. What type of compensation? Okay. احنا عم نعمل inhibition للسيجنال. شو الأذر thing اللي كان ممكن يصير؟ Receptor upregulation. Exactly. So when you try to do such thing, the first thing to think about is that the compensation in the body will be by receptor upregulation. So how is that going to be a big problem? If you stop the drug abruptly, the first thing to think about is a severe rebound hypertension. And this is exactly what we know about clonidine. Clonidine is a good drug as a last resort. When you have no other choice and you need a strong antihypertensive drug, clonidine might be your choice. So that's why it's indicated in resistant hypertension. Okay? And it's now part of the recommendations of the American Heart Association for resistant hypertension. But the only thing to think about and to take care of that rebound hypertension and severe one might result if you stop it abruptly. Okay? So what people do actually is like using the steroids in the case of severe asthma. So if the patient has severe resistant hypertension, you might use a short course of clonidine for a while and then start tapering down. Okay? You do not continue on that drug forever, but gradually stop the drug. مش عارف شو صار من شيء فلت هون. طيب. Then the next class we will discuss are the RAS inhibitors, and as we said yesterday, it's the renin, angiotensin, aldosterone system. Now, the most important thing to know about this from physiology is that this is a twin system to the sympathetic flow. Okay? Now, they are both activated maybe by the same stimulus, which is the reduction in the mean arterial pressure. Okay? Once there is a reduction in the mean arterial pressure felt at the juxtaglomerular cells of the kidney, renin will be released. Okay? That will lead to the activation of the whole system, so production of angiotensin 2 and aldosterone. Angiotensin 2, what's the major function? The major thing is a potent vasoconstriction. Now the other thing, as we said yesterday, it might be overactivation of the sympathetic system. That's why we call them as twin systems. And the third thing is the activation of aldosterone. Activation of the production or secretion of aldosterone. What's the major function of aldosterone? Reabsorption of sodium and لا ماشي اوكي sodium and What about potassium? Loss of potassium or excretion of potassium. Okay, so increased reabsorption of sodium and increased excretion of potassium. Type. Because this is a very powerful system, and it's a twin system to the sympathetic tone and sympathetic flow, it became as an evidently effective way to treat hypertension by using inhibitors of this pathway. Okay, and actually we have several classes of drugs that belong to this major class, including the angiotensin converting enzyme inhibitors, the angiotensin 2 receptor blockers. We have renin inhibitors. Okay, they are recently introduced, and we have also what? Aldosterone receptor antagonists. اليوم حكينا عنهم امبارح. شو حكينا الالدوستيرون receptor antagonists could be considered as what? Diuretics. Okay, but what type of diuretic? What? لا شو له diuretics. Potassium sparing diuretics, which is the last class of diuretics. Okay, and aldosterone receptor antagonists are the or one type of the potassium sparing diuretics because they will increase the reabsorption and will not decrease or will not lead to hypokalemia. So let's forget about this type because we have talked about it before, and let's forget also about renin inhibitors because it's actually not available in Jordan, so that's not a big point. And let's focus on the most important tests, the ACE inhibitors and the AT2 receptor blockers. And let's start with the ACE inhibitors. As its name implies, ACE inhibitors are the angiotensin converting enzyme inhibitors. So what's the major function? Decrease the production of angiotensin 2. So stop the whole system, okay? Because angiotensin 2 is the core center of the system. Now, the most important or commonly used drugs currently are captopril, and as you see, pril is something indicative of this class, and enalapril. Okay? Now, it's important to know some practical comments about these drugs. Yeah. If I say that these drugs are, or this whole system is a twin to the sympathetic system, so what age group would you like to use these classes of drugs in? Young patients, exactly. So if the sympathetic tone is higher in young patients, so you have to know that the functionality of the RAS system is also higher in young patients. And that's why this is commonly used as first or second line in young individuals. Now, in general, what we know now as a consensus for the use of ACE inhibitors or angiotensin 2 receptor blockers is that these are the ultimate second-line antihypertensive drugs. Because as we said yesterday, we shall focus on, for example, diuretics, particularly thiazide diuretics, as a first line in elderly, which is the most frequent age group for the development of hypertension. Now, once you don't have any function or diuretics lose their efficacy, you have to start the combination therapy, okay? And your ultimate second-line drug is the ACE inhibitors or the angiotensin 2 receptor blocker. Now, will that help to increase the efficacy of diuretics, for example? اللي بيحكي يس ليش ونو واي؟ مين بيحكي يس؟ If I add ACE inhibitors or angiotensin 2 receptor blockers to the treatment of diuretics, will that increase the efficacy of diuretics? بس على قد الصغر؟ طيب هيك هم مع مين ضد انه it will increase the efficacy of yes okay yes renal blood flow okay ماشي طيب هو يعني بالعكس anyways, شوفوا أنا حكيت لكم امبارح one of the most important factors that will determine the function of diuretics is the extent of counter-regulatory and compensatory mechanisms, right? And زي ما حكينا the major effect of the diuretics will be on the blood volume, okay? That will be reduced. So once that is reduced, the mean arterial pressure will be suddenly decreased. So what will the body respond by? The baroreceptor reflex and the renin reflex, okay? So the sympathetic overactivation will happen and the activation of the renin angiotensin aldosterone system will happen. So what's going to happen to the equation? You're going to go back to the balance. If I am decreasing, for example, cardiac output at the end, by activation of the sympathetic system and the renin angiotensin aldosterone system, I'm going to increase the peripheral vascular resistance again, right? So what's going to happen to the blood pressure? It's going to increase again. So one major factor you have to know, and we will discuss more in more details next week, is that when diuretics lose their function, think about that there is a counter-regulatory mechanism. Okay? So that's why I should start using a combination therapy, either by introducing the beta blockers or one of the drugs that will affect or inhibit the RAS system. You got it? So that's why it's an ultimate second-line antihypertensive drug. Now, take another fact into account, is that they have found recently that the ACE inhibitors, particularly, could affect the cardiac structural remodeling in heart failure. So one thing that we are afraid of always, post-MI, and at the beginning of heart failure, and you will know in a few days, that there is structural remodeling of the heart. There is hypertrophy, maybe dilatation, and that will lead to the loss of the function. So one thing that they have discovered recently is that ACE inhibitors could inhibit structural remodeling. And that's why it's considered part of the regimen for the treatment of patients post-MI or during heart failure, if they have hypertension. Now, as we said, for young patients, the thing which is interesting, most of these old drugs, particularly enalapril, for example, are prodrugs, which means what? That they need activation prior to functioning within the body. And that happens mostly within the liver. So if you have a problem with your liver, there's no point of giving the prodrug, okay? Which is a problem. Another thing which was also a problem for ACE inhibitors was it is absolutely contraindicated during pregnancy. The frequency of teratogenicity was found to be very high. And that's why always think about not using ACE inhibitors in pregnancy. Another fact which might not be, it's not mentioned here. New studies have also found that there are racial differences in the response to ACE inhibitors. For example, they found that black people might not respond very well to ACE inhibitors compared, for example, for the Caucasian races. And this might be due to lower levels of renin in black people. Okay? So this is something in the USMLE exams, if you have a black patient, okay, think about not using ACE inhibitors as a first-line antihypertensive drug. And the other class I will mention in a minute will be your first choice. But what could be the side effects of ACE inhibitors? The most important one will be hypertension, okay? And this is a drug that you might need to have a very low dose at the beginning and start gradually building up the dose. Again, anything that is a potent vasoconstrictor, you lose that, think about postural hypertension and first dose hypertension. So start the dose at lower values and start building up, and give the first dose when at bedtime until the patient starts responding and adapting to this reduction in his vascular tone. What else? What about the potassium? Black, okay. So it's hyperkalemia. As I said, angiotensin 2 is the core of this whole system. If I inhibit angiotensin 2, aldosterone will be inhibited. If I inhibit, not inhibited as a function, but the secretion of aldosterone will be reduced. If I lose aldosterone, then sodium reabsorption will be what? Decreased, and potassium excretion will be increased. Decreased, and that will lead to hyperkalemia. Okay, and this is also something you have to worry about in these drugs, is that they cause hyperkalemia in addition to hypertension. Now, the last thing that it is commonly encountered. I mean by commonly, it's about 10 to 15% of the patients who use this treatment will complain of a very severe, irritating, dry cough. Now, how does that happen? Now, this happens due to this pathway. angiotensin 2 is converted, angiotensin 1 is converted to 2 via the angiotensin converting enzyme. Now, one side pathway or side effect of the angiotensin converting enzyme is the production of bradykinin. Now, bradykinin is a vasoactive substance which leads to vasodilation. Okay? In addition to that, this bradykinin is very severely irritating for the airways. Okay? Now, if you know that ACE is mostly located within your lung, okay, you will know that bradykinin is mostly produced within your lung and airways. And that's why, of course, ACE will not produce bradykinin. It will degrade bradykinin. Okay? So if I inhibit ACE as an enzyme, what's going to happen to the level of bradykinin? It's going to increase. And think about the location. It's going to be mostly within your lungs, and that will lead to severe irritation of the airways, and that will lead to a very severe dry cough. This is one of the major reasons for the poor compliance on these drugs. Okay? Your patient might, okay, I'm not going to take it, even if I will die. Because it's a dry cough, irritating, it does not stop. And you as a physician have no choice. Okay? You cannot stop it. How can you avoid this? If I want to maintain, if this is an important pathway, how can I reduce dry cough? لا ما زبطش. هاي إنه تعطيه any anti-cough وكذا ما زبطش. لأنه still the bradykinin level is very high. لا, still the same problem. Bradykinin will be accumulated within the airway. لا, إحنا بدنا هسه هون. أنا بدي أحافظ على الفانكشن أو بدي هاي الفانكشن تكون موجودة. Inhibition of the renin angiotensin aldosterone system. بس ما بدي البراديكاينين يكون موجود. شو الحل؟ أسهل من هيك. Yes. ما فيش. مش موجود. Yes. Exactly. So instead of giving the angiotensin converting enzyme inhibitor, okay, go to the last step, which is to inhibit the receptor itself. So forget about the angiotensin converting enzyme and give an angiotensin receptor blocker. Okay? And this was introduced also recently within the last 20 years as a solution for the problem of the dry cough. Okay? We have candesartan and valsartan, for example, and many more recently introduced. Now, what is the major advantage over ACE inhibitors? It's only the reduction, or there's no dry cough, or that's what we know. Now, will it be more effective or more potent? Actually not, because the last effect, or the last step, is going to be produced by both of them, which is inhibition of the RAS system. But this will have an added advantage of preventing the dry cough. But that will be on the expense of what? The cost. ACE inhibitors are very cheap, okay, not as cheap as the diuretics, but this is like 5 to 6 times more expensive. Like one pack, for example, of candesartan, I guess, is 30 to 50 JDs. Okay? عشان هيك بالمستشفيات اللي بيكون فيها تأمين بتلاقيهم مش معلومة. So they are very expensive, but for some people they might be very helpful because they will be complaining of a severe dry and irritating cough. طيب. فهمتوا؟ ماشي. Then another class will be the calcium channel blockers. And if you remember what I mentioned during the antiarrhythmic class, that we have two major types of calcium channel blockers. We have the non-dihydropyridines, which are verapamil and diltiazem, and the thing that you have to know is that they will affect the calcium signaling on both the heart and the blood vessels, but most of the effect will be on the heart. Now, another class which was introduced after that was a class of dihydropyridines which will affect the vessels and will not have an effect on the heart. Okay? That's why these are reserved for use as antiarrhythmics, because most of their effect will be on the heart. Okay? Can I use dihydropyridines as antiarrhythmic agents? No. Because they affect the vessel. And what kind of effect on the vessel? What will they produce? Vasodilation. Exactly. You inhibit the calcium influx, and that will relax the muscles, and that will lead to vasodilation. These are considered as antihypertensive drugs. Okay. Can I assign it to my, if you would like to remember? Now, what to know in practice about calcium channel blockers? Okay. The first thing that you have to know, if you just remember that I said black people, for example, have low renin levels, and their response to the RAS system inhibitors is not that much. On the other hand, the same studies found that the response of black people to calcium channel blockers is much, much higher. Okay? I don't know why. Maybe the muscular mass in black people is more, so the calcium signaling is more pronounced. So if you inhibit that, the effect on, or the vasodilatory effect would be higher. Nobody knows exactly. So it is considered in the state as a first-line antihypertensive for black patients. Okay? Now, is it considered as a first-line antihypertensive in our settings here? Actually, not. If you go back, we said that the diuretics are the best overall, comprehensively. Okay? Safe, inexpensive, and effective. If we have young patients, we might use beta blockers. Ultimate second line will be the RAS system inhibitors. So calcium channel blockers are not considered first or second line antihypertensive. Now, what we do is, when you have a patient and you started your combination regimen and there is no response, you look at the list of antihypertensive drugs and you start adding drugs. Your patient is not responding. You have added diuretic, beta blocker, plus, for example, ACE inhibitor, and there is no response. What's next? You might add the calcium channel blockers. Okay? So look at it as if it is third or fourth line in the treatment of hypertension. One thing that is annoying, without a particularly known mechanism of action about calcium channel blockers, they cause edema at certain places, like for example lower limbs, face, okay, in the patients, and it is very annoying. We have no idea how that happens, okay, and we cannot predict whether it will happen in this patient or not, because it happens in some patients, it does not happen in other patients, okay, and this might be a reason for stopping the drug. So you have to know that if I presented to you a case of a patient who was started on a calcium channel blocker or on a drug, and he suddenly started complaining of face edema, lower limb edema, think about this might be a calcium channel blocker. Right? I might ask such questions in the exam. So people say that they have intrinsic natriuretic effect, okay, which means what, they increase the sodium excretion. But at the same time, okay, I'm telling you that something bothering is that they will cause edema at certain places. For me, this was hard to understand. How does that correlate or fit with that idea? But what I found is that they are totally different in their mechanisms. Calcium channel blockers might have some diuretic effect, okay, which is not pronounced, but at the same time it might have or affect the interstitial hydraulic powers and so on, so they might lead to increased permeability into the interstitium. What physiology lectures discuss with you about the development of it. Again, for black patients, they are an advantage. What side effects would you consider for these drugs? Hypertension is one. What else? Edema, as we said, okay. Face edema, lower limb edema, okay. Now, something that's also encountered and it's bothering for patients is constipation, okay. Do you know how does that happen? Yes. Okay. Okay. Yeah, that's exactly. It might be that you are relaxing or too much relaxation for the intestinal smooth muscles. Okay, that might lead to constipation. Now, this is also commonly encountered, so you have to educate and communicate with your patient about this side effect. Now, another thing which might be related to effects on the cerebral circulation is headache. So, in addition to the face edema, they start having headache. This is totally bad, okay, for a patient. But they are not uncommon. You might see them in a lot of patients. But I guess this will be the last class of antihypertensive drugs. The direct vasodilators. Now, this is interesting because the mechanism of action is interesting, and I want you to follow me with this diagram about that. Now, as we said, the major regulator of the contractility of the vascular smooth muscle is the calcium influx, right? Now, these calcium channels are mostly voltage-gated channels, which means what? That they will be open and active only during depolarization. So once the membrane is depolarized, calcium influx will ensue. That's why we call them voltage-gated calcium channels. If that's true, then the major reason for inactivation or closure of these channels would be what? Repolarization. Okay? And this is exactly what happens. Once the action potential is repolarizing, okay, and that happens mostly due to what? Potassium effluent. Okay? Once that happens, these channels will be inactive and closed. Now imagine if I took this membrane potential even lower than the resting membrane potential. What do we call this? Hyperpolarization. Okay? And this also might be related to more and more efflux of potassium. Now what's going to happen to these calcium channels? They are going to be even further inactivated and closed. Okay? So once that happens, the contractility of the muscle will be reduced. Okay? And this is exactly what we do with direct vasodilators. We just stimulate as agonists for the hyperpolarizing potassium channels. You send the membrane potential even lower than the resting membrane potential, and that will have a more negative impact on the calcium influx into the cell, and that will lead to vasodilation. Now, the drug that we have in practice is hydralazine, okay? And it's available in both formulas, the oral and the injectable formula. So it could be used as a maintenance drug at home-based, and it could be used in the emergency. Okay? But what could be a big drawback for using the direct vasodilator? Okay, so the first time you have to think of severe hypertension. Something also in response to such hypertension will be what? Exactly. And this is the major drawback for the use of the direct vasodilator, is that you will have severe hypertension, okay, and that will be compensated by severe reflex tachycardia. So how do you manage that? Give a beta blocker concomitantly with direct vasodilator, which is not going back in the same direction. More and more drugs for our patients. So if I want to use this, the only way to use it is to combine it or to give it concomitantly with a beta blocker. And this is actually what happens. Now, another thing which is bad about hydralazine is that it has a short half-life, which means what? That the frequency of dosing will be high. And if I want to inject it, I have to continuously infuse it into the patient. and that will lead to more and more hypotension and more reflex tachycardia. So is it going to be easy to be given to a patient, whether in the emergency or at home? Actually no. And that's why, is it a first line, second line, third line, fourth line? No. It's a last resort. Okay? You have no other choice. You might think about it. The efficacy, will it be high actually or not? Actually not. It's not going to be very high. Again, go back to the compensatory mechanisms. So I have to use all these drugs that will target the compensatory mechanisms for this to be very effective. Okay? But it might be helpful for me as an emergency doctor. I want to infuse something to the patient that will produce like too much vasodilation all of a sudden, and that will lead to reduction in blood pressure rapidly. So hydrolysine might be a good choice, or direct vasodilation. Yes. Yes. Sophie, you lose all practical points in like 2/3 of the patients. This is a secret between us. This is something you have to know. Treatment of systemic conditions, and particularly if you do not know how that happens from the beginning, is totally hard. It might work for a while. You start getting no response. You start giving combination therapies. You start getting into too much trouble in your brain and in the body of the patient, because this might act against that, and this might cause a side effect that will inhibit the function of this drug, and so on. And you get into a dilemma. At one point you say, okay, you go to the list. I gave him this, and that. It's a maximum dose for all of these drugs. What's to do? Go to the next one. And in almost 1/3 of the patients, that will not work. So we need some brilliant doctors to invent something new to solve this problem, which is a really big problem. Ask any cardiologist or internist about the treatment of systemic hypertension. And don't forget, which is something I will mention later in the final lecture. These diseases do not come alone. They come as a package, something we call the metabolic syndrome. He comes to you obese, with hyperlipidemia, he is smoking, and he's having systemic hypertension. At one point he starts diabetes and insulin resistance, and then he gets into heart failure. Very nice dealing with such patients. And unfortunately in our region, this is the type of, at least in our hospital, this is the type of patients you will deal with. Okay? Because it's a tertiary hospital, you get too complicated cases. Type. Used with a beta blocker, used in acute emergency hypertension, as we said. Now, something that's common for exams, exam questions. Hydrolysine is one of a few drugs that were found to cause something called lupus-like syndrome as a side effect. شو lupus-like syndrome? Lupus is تعرف زي الأساليب for example أو كذا إنه السيمبتومز تبعتهم هي arthralgia ومyalgia وfatigability and so on. Hydrolysine causes something close to that picture. So your patient might complain of arthralgia, myalgia, and so on. But how does that happen? Nobody knows. But this is a common example. Hydrolysine or all of the following drugs cause lupus-like syndrome except. So you have to know that hydrolysine causes such syndrome. Memorize. It's something you like, I'm sure. طيب. قبل لا نخلص نحكي بس كلمتين عن something called hypertensive crisis, which is what? Which is having your patient, having a patient whose blood pressure is more than 180 systolic over 110. Okay? Now we have two types, hypertensive urgency and hypertensive emergency. Which is going to be more severe and life-threatening? Emergency. Okay? Now, so what's the big difference between them? The blood pressure readings are almost the same. More than 180 over 110. The difference actually is in something we call end organ damage. Now, this elevated blood pressure might lead to end organ damage in some patients. What end organs we mean? Mainly it's the brain, and that will be manifested as stroke. Could affect the heart, and this be manifested as ischemic heart disease, okay, or heart failure. It could affect the kidney, and this could be manifested as renal failure. So what I do when I have a patient who's having very high blood pressure readings, okay, the first thing to do is what? Is look for signs of end organ damage. If he has end organ damage, this is an emergency condition. If he doesn't, this is an urgency condition. Why do I need to differentiate it? Because the treatment is totally different. What's the major treatment? Or what's the major treatment difference here? It's actually how fast and how quick should you act. In a patient whose blood pressure is so high and that caused severe end organ damage, the reduction in blood pressure should be very quick. Okay? You have to reduce the blood pressure on the spot. You don't have any time. While in a patient whose blood pressure readings are so high, it might be a chronic thing. Okay? And that's why you do not need to reduce the blood pressure so quickly. And actually, it might be contraindicated to reduce the blood pressure so quickly. Why? Because as I said, this might be a chronic problem. His body has adapted to such high readings of blood pressure. So maybe the cerebral blood flow, for example, depends on such high pressure. Okay? So if I reduce the blood pressure all of a sudden in that patient, that might lead to what? To end organ damage. So it's important when you have a patient in the ER, the first thing is, for example, do a CT scan, okay, to exclude that they have stroke. Do a rapid kidney function test. You might do also ECG and cardiac enzymes to look for damage for the heart. If they do not have it, you can start the treatment, but gradually. Now, what is the most common cause for example, hypertensive urgency? And don't forget, I'm saying it might be a chronic problem. Mostly it's the patient's poor compliance to the drugs or bad dosing of drugs. So maybe the only thing you have to do for your patient will be what? Either increase the doses of the drugs, correct the doses of the drugs, and convince your patient that you have to stick to the treatment. Okay? So that's the major reason for hypertensive urgency, and that's why you cannot treat it so quickly in the ER. Now, for hypertensive emergency, I just want to mention two types of drugs without too much details about their mechanism of action and so on, but this will be discussed in the ischemic heart disease lecture, anti-angina lecture. The sodium nitroprusside, and we have also labetalol, which as you will guess is what? A beta blocker. Both of them are readily available for you in the ER to be used for the treatment of emergency hypertension. So that means the onset of action. But what's the big difference between them? It's actually the duration of action. For this, the duration of action is 1 to 2 minutes. For this, it's 3 to 6 hours. Which one would you prefer? This one? This one? لا احنا هون بنحكي hypertensive emergency. For urgency, we're not going to use them. زي ما حكيت. Urgency, you might need to modify the doses, give a higher dose of a drug to reduce the blood pressure gradually, and so on. I'm not going to need to use such therapeutic regimens. Okay, كل شيء له good and bad sides. For example, the good thing about this is that it has an immediate action. Okay, short duration of action, which might be good. Why? Because you can control the effect. Okay, you can exert some sort of control. It's not going to last forever. While for this, it's a very long duration, so my control will be poor on the patient. Now, at the same time, if this is too short of a half-life, I have to infuse it continuously for the patient, which means what? I have to admit my patient to the hospital. Okay? While this might be an ER-based therapy for 4 hours, if the blood pressure is, mostly we have to admit that this is a hypertensive emergency, but I mean control-wise or predictability-wise, this could be more and this could be poor, and the duration of action is longer, so I don't need to infuse labetalol continuously for the patient. فهمتوا أهم شيء الديفرنس ما بين الأرجنسي والإمرجنسي؟ ماشي. طيب. آخر شيء أعطيكم بس short examples about how to deal with clinical cases. I'm not going to discuss science here. I just want you to know how to deal with a question of clinical cases, which is what you will be encountered with in the exam. For example, if I give you this case, and this is how the question comes to you in the exam. What's the most important thing in reading such questions? You have to do it in the exam. It's actually highlighting the keywords. Okay? Highlighting the keywords will find you the answer. For example, the age here is what? Is a keyword. Because for younger people, we said beta blockers and ACE inhibitors. For older people, we said diuretics and calcium channel blocker. Another thing is the comorbid diseases. We said if it's an MI or heart failure, think about ACE inhibitors and beta blockers. Okay? Another thing is to think about what else is accompanying the case. For example, this is a case of fluid overload, pulmonary edema. Okay? So that will lead you to the answer. Combine all these keywords together and you will find the answer. This is an old patient having heart failure, having pulmonary edema. What's the best choice of a treatment? زي ما حكينا بالfluid overload states, loop diuretics in the emergency department are the best. Okay? And he's an elderly patient. Okay? So that's going to be great. Another question with highlighted keywords. Again, an 84-year-old lady. So that's an old age. She has stage 2 hypertension. You should know this, right? Okay, you decided to go for combination antihypertensive therapy. Okay? She's just old and you need combination antihypertensive therapy. What's your double therapy from this list? طبعا هاي كل الكلاسز اللي حكيناها. ضلنا نقول. طيب, the first line will be what? That's a given. That's an old lady, old patient, hypertension. It's mild to moderate because this is a stage 2 hypertension. The first thing to think about is thiazide diuretics. Okay? What's another class of these will you choose? Why? Exactly. For the age group, calcium channel blockers might be effective as a combination therapy with diuretics and such. A third case, a 50-year-old a 50-year-old man. So that's not a very old patient. He's not very young. It's considered in between. But the important thing is that he is an acute myocardial infarction case. Okay? And you want a combination therapy. Actually, what is your best therapeutic regimen from these classes? And ACE inhibitors. So life is easy, right? So beta blockers and ACE inhibitors are the best double therapy in such patients. So always highlight the keywords, put the facts, the data together, and compiling and get to the answer. Okay? Do not be tricked by a single word or a single fact. You have to take all these facts together to come to the right answer. Mashi. We're done. Any questions? Yes. You can leave, of course. No, يعني خذوا البريك بس الحالة دي. اسأل مين تسأل ولا حاجة.